steering committee and for the work group. So the purpose of the meeting is to review data for the collaborative SMART goals, consider new work in the community, and consider how decisions will be made moving forward. So we can do some introductions. I introduce myself. Do we want to go around for everybody that's here and introduce for the new folks that are on the call today? Krista, do you want to start? We have to start somewhere, so I'm going to call out on people.
Sounds good. I wish I was in this background for real, but I'm not. Krista Fritzen, licensed clinical psychologist, UNK professor, and director of Beacon Central. Instead of Beacon Kearney, now it's Beacon Central to represent this area, and also get to be involved with the local outreach to suicide survivors.
I'll go next. I'm Peggy Reicher. I'm the executive director for the Brain Injury Alliance of Nebraska. I'm located in Lincoln, but we serve statewide, and I'm going to bounce it over to Brenda Horner, who's also with my staff.
Hello, I am Brenda Horner, resource facilitator for the Central region. I'm new here, maybe 2 months. So glad to get to know everybody.
How about Jessica, then Diane, then Jill?
Hi, I'm Jessica Vickers with Live Well Counseling.
Hi, I'm Diane Duffin. I'm a professor of political science at UNK, and I'm on the board of Buffalo County Community Partners, where I chair the Committee on Accountability, Impact, and Measurement.
I'm Jill Schubauer. I'm with Region 3. I'm the youth system specialist.
How about Nicole, Michelle, and Martha? You're right. You're on mute, Nicole. Of course.
Never fails. I know. I'm Nicole Hirsch. I am a CFS supervisor with the Department of Health and Human Services. So thank you.
Good morning. I'm Michelle Tucon with Buffalo County Community Partners.
Martha Marfileño with Buffalo County Community Partners.
Abby, Denise, and then everybody at the conference room for Buffalo County.
Hi, Abby Olson, Director of Care Management and Social Work at CHI Good Samaritan and St. Francis, and Richard Young.
I think it was me. I'm sorry. I need to be more intentionally focused this morning. Denise Weiner, Buffalo County Community Partners.
My name is Eduardo. I'm with the Buffalo County Community Partners.
I'm Ellery Butterfield. I'm the youth coordinator for Buffalo County Community Partners.
And Matt Morris with Community Partners over here in the corner.
All right. Thanks, everybody. I appreciate it. Did everybody have a chance to review and look through the September steering committee minutes? Yes. Did we have any questions? Okay. So our purpose, I guess, just moving forward with collective impact, results-based accountability, impact statements, governing and overseeing the collaborative, those are kind of the purpose of our steering committee. But I want to talk about kind of where we've been with this and where we're headed. So we've met a few times in person to kind of get direction and establish some SMART goals, things that we can work towards, things that are measurable, that are timely. So we can talk about those as well. But we've also talked about how to collaborate as a team and who else we need to bring to the table. We also talked about some short-term and long-term goals at our last meeting of things that are tangible that we feel like we could do right now. Denise, do you want to talk a little bit about those, or are those later on the agenda?
I can jump in later. How's that?
Okay, yeah, that sounds perfect. So I'll go over our SMART goals as well. Those are attached. So what we've kind of settled on is for goal 1, ensure all children and youth ages 0 to 18 have access to preventable programs, services, training, and resources by engaging with Buffalo County Wellbeing Collaborative members in documenting current funded prevention strategies by the end of next year. So this is how much we're doing. So we're going to gather prevention strategies in a tool listing the programs of collaborative partners and intended age range served. Members of the collaborative will report out number of families impact and identified gaps or issues in prevention system, and consider adding depth to the partner data by tracking referrals, potentially through a database. Goal 2 is to decrease the number of children, adolescents, and youth with adverse experiences that are preventable. This will be reported through the Buffalo County Youth Crime Commission data and crisis response data and premature deaths. So we want to reduce that by 5% by the end of next year. And then our third goal is to host 1 to 2 focus groups of youth and parents with lived experience with success stories. So people and families who have received services and not re-entered the system. And we want to be able to present that to funders, community partners, and broader community providers by the end of next year. Does anybody have any questions about those? Okay. And then we've also added some additional people to the group today. So we'll have Jill talk about youth crisis data. Doug, if he's on, not on, okay. Youth juvenile justice data. Abby, if she could talk at some point about youth hospitalization data. Doesn't look like Central Plains is on either, but they were invited for youth homelessness. Lacey, it doesn't look like is on, but youth mental health admissions. And then Peggy and Brenda maybe talk about youth brain injury. So those are the additional people that we've added to the team, and that's some of the data that we want to gather for this group as well. So if there's anybody that or any organizations that we feel like we're missing, just let us know and we can add additional folks to our calls.
Emily, I will mention too, I do believe Peggy said that they have another engagement, and if they could go sooner in the agenda, they would be appreciative. And
okay. I want to go through those right now.
When you're ready, I just wanted to mention that.
Oh no, I'm good. Yeah, Peggy, do you want to share a little bit about Brain Injury Alliance and any data that you might have to support youth brain injury?
Yeah, I sure can. And thank you for, I'm able to stay on until 11, and I know Brenda's able to stay on through the whole time, but I had a hard stop at 11. So appreciate this opportunity. We, within the Brain Injury Alliance in Nebraska, we've been trying to really focus on high-risk populations, and kids within the juvenile justice system definitely fall in that high-risk area. We're finding if you were to look at the CDC, the general population, they're going to say about 8.5% of the general population has had a brain injury. What we're finding is youth within justice-involved youth is much higher. We've got a handful of different programs right now doing some screening for us, and programs that are looking within the community programs, such as we've got a program here in Lincoln called Cedars that's been doing some screening for us. They're screening about 53% of those kids are screening positive for brain injury. Again, all of this is compared to about 8.9% of the general population. North Platte is also doing some work for us, and about 13% of those youth are screening positive. As they get deeper into the system, we're finding much higher rates within the diversion programs. We're seeing it's closer right now to about 51% of those youth are screening positive. So again, deeper in the system, the higher the prevalence of it. What's been really interesting in doing our screening is that it's not just one injury, it's multiple injuries. And the majority of these youth, up to 40 to 50% of them have had 6 or more injuries. So when we think back to, we care about youth that are playing sports, we care about all youth, but we've got a laser focus on kids playing football. If they have 1 or 2 or 3 concussions, you're like, let's figure out a new thing for you. but no one's asking the question within these high-risk populations. What's also then happening is they go unsupported. People aren't asking the right questions. If you were to ask the question, do you have a brain injury, is not the right question. Most of these youth are also not identifying as having a brain injury. Many of them have said they've never gone, usually about half of them have not gone to the hospital. They've not gone to see Abby and her crew. They're typically just kind of brushing it off, and no one's talking to them about it. It's not being captured in the school systems either. So the screening tool is not a diagnostic tool by any means, but it's a matter of setting up and asking the right set of questions. Majority of these youth have also had their injuries because of assaults and car accidents. They're not necessarily sports injuries. A lot of them, as we go through our screening, we're not asking who hit you, but one would suspect within the certain populations, we also see high risk of domestic violence, and it could be stuff that's happening within the home, the four walls within their home. So it's, I guess those numbers are high enough. I'm super excited that you guys have asked us to be a part of this because there's definitely a strong correlation between brain injury and those within that system. At this point in time, we do have the YRTC is doing some screening for us, both the Kearney, Omaha, or the Kearney, Hastings, and the Lincoln campus, but we're hoping to dive into that a little bit more. So that's, I don't know how much you want me to go on. I could go on for another 30 minutes, but that's the overview. I'm happy to answer any questions that folks might have.
Peggy, this is Martha. You said one of the things that you said that to ask if you have a brain injury wouldn't be the correct way to ask that. What would be the best way to capture that if we're trying to ask people if they've had a mild injury to their head, or be able to capture whether it's been a brain injury or not? What's the best way to ask that question?
Yeah, we have a tool. It's called the Help Screening tool that we've been utilizing. All these programs have been utilizing it. It's a matter of setting out and asking, doing some interviewing. The interview takes about 5 to 7 minutes. It's not long, but it's asking, have you ever been hit in the head? And what it looks like, we kind of rattle off, here's the different ways in which you could have had a hit. We're also looking at strangulation, recognizing that acquired brain injury also can cause just as many issues as a traumatic brain injury, which is a bump or blow or jolt to the head. And we're also asking about, is there a change, a loss of consciousness, or an altered state of consciousness? You don't have to have a loss of consciousness in order to have a brain injury. You can be without oxygen, and some of the choking games and strangulation kind of things are also causing brain injury. So it's an acquired brain injury. So we're trying to figure out how long, and it's all self-reported from the youth. I mean, we're not going back and looking for the medical records, because 50% of these kids are not going to the doctors. It's not going to be in your medical record. And so, and I can share that screen with, I don't know if it's you, Denise. I know I've got your information for sure. I can share with you all the tool that we've been utilizing and certainly provide you with more information. The other thing I'll add is, if any of you go, oh my gosh, we need to know more, and I think all of you do, we are more than happy to do a presentation for you and your staff and kind of dive in a little bit deeper with what brain injury looks like and what are some strategies. The other thing that's important to know about this is not rocket science. You don't have to be a brain injury expert in order to better serve kids with brain injury, but you do have to recognize some of the simple signs and symptoms, and then be asking, always asking yourself the question, is this a can't or is this a won't? And a lot of these kids are dealing with deficits. It's not defiance, it's deficits because of multiple brain injuries. And I think we want to kind of sometimes label them. And I'm not saying we excuse what they've done, but what we do need to do is look at how can we better meet their needs and understand where they're coming from and be more trauma informed from that perspective.
Peggy, when you said that the YRTCs and Cedars are doing screenings, are they also using that same tool that you just mentioned?
They are.
Okay.
I have, so at this point, the tool that we're utilizing is not what's considered evidence-based. So that kind of sends some red flags to folks. By January 1st, we're going to be switching over to an evidence-based tool that multiple folks are using across the nation. And it's called the OSU TDI screen. That stands for Ohio State University TDI screen. And then we'll be able to do some comparisons with other states also doing work in this area.
Does anybody have any other questions for Peggy or Brenda? Well, thanks for that information, Peggy. My wheels are just turning about probably how we need to continue to work together with the platform and maybe loading some of those tools on there. So when you're working with other agencies, they can see that screening tool. So I'll get with you and we'll chat more about that.
Yeah, that'd be great. Thank you for the opportunity. And again, if anybody wants to do presentations, happy to do that.
Peggy, there's a question in chat from Krista for you.
Oh, okay. I didn't read chat. I should read.
It's okay. She just asked if you could do a presentation to her UNK students.
I added that. I'll send an individual message. Sorry.
Yeah, happy to do that, Krista.
Jill, do you want to share next about youth crisis data?
Yes. I can share the screen, right? I think so. I can bring up a table if everything works good. Okay, can you all see that? Yes?
Yep.
Okay. This is just a brief summary of the youth crisis response youth that have been served from fiscal year 2019 through 2022 fiscal year, which ended June 30th. And what this data captures is obviously by county, the youth that were seen, or there was a call into either the CSU at Mid Plains and Grand Island, or South Central Behavioral Services in the Hastings office or the Kearney office. So this could be mobile crisis response or in-person crisis response, like coming to the office. So these are kind of our numbers. I highlighted Buffalo County throughout the years. And as you can see, Adams, Buffalo, and Hall are the largest amount of youth served. Hall is quite, inflated because of the CSU being right there. And also Grand Island Public Schools uses the CSU to do some of their further screenings for suicide risk. So we've always seen quite a large number in Hall County, and even across the state, Hall County is showing high numbers due to that CSU being there. But if we want to take a look at Buffalo County, that's probably what most of you are most interested in. These are youth that have reported residence in Buffalo County that we're seeing. So you can see in 2019, we had 20 youth, and the youth definition in crisis response is between the ages of 0 and up to the age of 19. And in 2019, we saw 20 youth, 2020, 22 youth, 21, 17 youth, 22 youth. So very consistent among Buffalo County. And honestly, I think all the counties are fairly consistent. Probably saw a dip just a little bit in 21 just because of COVID related types of things. I'm not sure what else that you want me to share with you. Buffalo County and all of our other counties tend to be probably lower as far as crisis response. If you go across the state, Lincoln and Omaha have the largest numbers of crisis response youth. And then as you get into the more rural areas, you see a decline in families accessing youth response. I don't have the data from the Nebraska Helpline or now known as the 988 line. But that data is available if that's something that we would want to look at. So this does not capture any helpline calls. These are just direct, either warm handoffs from the helpline to those crisis response providers or the family or whoever calling the crisis response provider themselves. Questions or more information that you want from me? Because again, I could, as Peggy said, I could probably talk forever, but what do you guys want to know?
Jill, I should probably know this answer, but one of my questions is in regard to those children and youth that are being seen, what type of data do we have collected in that RBA model? So here's, how much are we doing? Do we have any data on how well these services are being perceived by those receiving them? And then is anyone better off because of this DOSA prevention? I'm just curious if you have some data in those realms as well.
So with crisis response, probably the hardest thing to get is follow-up data, because it's usually a one-time service, seen and gone, where they're not coming back into the office and seeking, additional services or the same service. They may refer them over. It just kind of depends, Denise, on the type of data. We did collect data through our Systems of Care grant. I'm going to get a tickle in my throat. Related to like where they were referred to, how many kids that came in were referred to psychiatric hospitalization, how many stayed at home, how many were diverted to a family friend. Oh goodness. But as far as follow up, if they're doing better now, we're not able to follow up with them. Goodness.
I'm so sorry I put you on that while you're trying to get rid of your tickle in your throat. I'm just going to talk for a couple minutes so you can kind of collect yourself. I think that's really interesting and something for us to consider, that maybe some of that systems of care collection might be helpful to talk through as well. Yeah, and I think even that Unite Us forum, what does that look like if those referrals were made through that system? What would that referral collection of data look like? Maybe, I don't know, I'm just thinking out loud and giving you some time to clear your throat.
I think I might be okay now. I can try to find, let me see if I can find this other report. I don't have it up and ready that we put together that shows like how many youth went into, were referred to the psychiatric hospital, how many were stayed at home with a safety plan. Let's see.
Re-entry, would you be, these are unduplicated numbers? Is there re-entry data?
These are not, these are not unduplicated. So this isn't per youth, this is per incident. Let's see, this is, oh gosh, that's an old one. Found the report. I just need to find.
While you're looking, I have a question. I'm sorry if I missed this. How many of these youth from these other smaller counties would then be potentially getting help in Buffalo County that we would be serving? Is this saying like 3 of them in Clay County, they got support in Clay County, or they got support from Region 3?
No, so what this is saying is when it says per county, it's the county of residence.
Okay.
Of the child.
Yep.
And then they could have either accessed the CSU in Grand Island, South Central in Hastings, or South Central in Kearney.
Okay.
Those are
thank
the
you.
only resources that we pulled from.
Okay, thank you.
Our numbers remained fairly consistent through, okay, I found through March. Fairly consistent what we were seeing across all of the years. Let me see if I can find, I'm getting closer. Okay, I think this is, well, I'll just show you the March one, or yeah, March one. I think Kale may have just didn't change the date on that other one, but I don't want to show you the wrong stuff. Okay, let me stop sharing this. Sorry, I could have been more prepared. Okay. Go down, try this again.
And no need to apologize, Jill, because we don't even know what to even ask for. So thank you for just starting this conversation with us.
That's okay. So, so this report, Kale in our office, he kept updating it every month. This is through March 31st of 2022. But what I was, you guys can see this, right? Yes. Okay.
Yep.
So what I was referring to is here on the side here, he keeps kind of a running tally of how many youth stayed in the home, how many were referred to the psychiatric hospital, and then how many were placed voluntarily. When we say placed, it's not a CFS placement. Voluntarily, the family said, hey, yeah, it might be best if they go to grandpa's house or something for the night. So this did remain fairly consistent. We did not see any jumps in numbers really as the through the System of Care grant 2017 to present. We always had somewhere between 65 and 68% of those kids that had a crisis response call remain in the home. Around that 30% were referred to the psychiatric hospital. One piece of data that we were not able to establish is this is just a referred. This doesn't mean that the family actually took them to the hospital or that they were admitted to the hospital. So they came in either to the CSU or on a call with South Central, and that therapist deemed that they should take them to the hospital. That's all this number means. And then we had, again, always around that 2.5% that that they chose for the child to go somewhere else, at least for a short amount of time until the crisis passed. So that's a little bit more data that we continued to collect. The psychiatric hospital, there just wasn't anything that, there wasn't any way that we could really hone in on a better number there. Because of the, you've got Mid-Plains referring to Richard Young, then we'd have to go to Richard Young and say, hey, did any of these kids show up at your door? And then how many of those kids were admitted? It was just, and then of course they all aren't going to Richard Young. Some of them are going to Bryan LGH or, other places. So there was just no good way to really formalize that data other than just keeping it as that's how many kids that they saw, about 30% that possibly could have met the psychiatric hospital criteria at that time. And then of course you have kids de-escalate on their way to the hospital too. So as far as satisfaction information, Denise, you asked about that too. We didn't collect satisfaction information specific to crisis response, and any satisfaction information would have been collected by the agency themselves, just as their normal satisfaction to services. All of the kids, at least all of the kids that remained on the crisis response call. We did have some families come in and they did not complete the whole referral or process or anything like that. But if they completed the process of that referral, sat down with a therapist, did some crisis planning, safety planning, all of the kids were referred to additional services though. So that was kind of one of our checks and balances, that the screening tools all came into our office. And then that was one piece that I did double check to make sure that all kids were referred to community-based services, basically, regardless as if they met, referred them to the psychiatric hospital, where else would that family be able to access services out after the crisis. So that was one piece that we did ensure. We were able to put together folders of resource information for the South Central and Mid Plains to give to the families that access crisis response, knowing that at the time of crisis, you're in no place to sit down and go, okay, so next week, where should we make a referral? That's not the point that family's at the time. They just want to get through the night. And so those folders were given to the families so that they at a later time could sit down and look at that information and see what services might be most appropriate for their family. Additional questions?
One more question, Jill. Trying to think about how to word this. Is there any data or whether it's qualitative or quantitative that could help us better understand from a community perspective what those families may see as gaps that they don't have services for, or what we could have offered to them? And maybe that's some of the work that you did with systems of care as well. Oh, you're on mute, Jill.
I thought I was already muted, so I muted myself. So we didn't collect data specific to that crisis response of what they would need. But I guess just in my work in general, probably the two areas that families are saying is in-home services. So when we look at these counties that are outside of our surrounding Hastings, Grand Island, and Kearney, the access to in-home services gets fewer and fewer. So, MST, of course, MST is not for everybody. But if it was for you and you live in Valley County, for instance, that's not accessible to you. And so in-home services is always something that I hear. And I just lost my train of thought of what the other one was that I was going to say. Well, let me think about that and I'll come back to it. And of course, and I'll kind of put a plug into something I was working on this morning, or kind of solidifying this morning, is we can have services out there in our array, but unless we know what services would best meet that family's needs, we're just kind of throwing darts at a wall and seeing what sticks. And so we just finalized a date, and some of you may have went through this training already with Bill Rubin. It's cluster-based planning. And cluster-based planning, what it does is he has put together a model of descriptions of youth that fit into 10 clusters of that's related. Mostly it's related to the youth's history. So as Becky was talking about brain injury, and that is some of that information of what has happened to you in the past, not necessarily what's going on today and trying to figure out what to do with you because of your behavior today, but understanding what has your experience has been in the past. And then also looking at behaviors, of course, and then identifying what Bill has done is then he's identified through these clusters what interventions that research says is most effective for kids in each one of these clusters. And so, Denise, when you talk about what service, what are the gaps, I don't know that we know that until we know what kids that we are talking about. So the partner program has been collecting cluster-based information for the last 2.5 years, probably. And it has been amazing to me that, and I'd have to look at the percentages, but the majority of our kids fall into the trauma cluster. Even though our kids are presenting with behavioral concerns. So they're truant, they're being kicked out of school, they're having law violations, and all of those things that we are all concerned about with our kids. But when we go back to their history, they have quite an extensive and alarming trauma history, some of them from prenatally, that we are able to identify and then look at that family and child accessing trauma-based services rather than services that might be focused on delinquency. So it's really helped us focus our thoughts and our information to our teams on what the most appropriate interventions might be. And most of these kids that you see on this chart are coming into crisis response with some sort of suicidal ideation. And when we look at those kids, because there is a cluster for kids with suicidal thoughts and behaviors, I think it's what it's called, like 2% of our kids fit into that cluster, like 2. But our kids that are screening high for suicidality in our partner program are probably 90%, but only 2 fit into that cluster because that's not the reason that their suicidal ideation is present. It's mostly due to trauma.
That is amazing, Jill. I'm so excited to hear that. I think that really helps us as a planning team to support the full collaborative in where their focus might be with parents. Thank you for that. I really think that's, do I want to say the golden nugget in what you've been sharing? Thank you. Thank you.
Yeah, and I can get you soon, not today, but I could get you data specific to where those kids are falling on the clusters. And then those services that kind of match those clusters to be able to see the availability that we have within our area to serve the kids. So yeah, of course, trauma-based interventions are always needed. And then down here at the bottom is the referral source. I didn't talk about that at all. It doesn't break it out into county, but just overall into our crisis response. You can see the majority, of course, school here, but I think Grand Island probably tips that scale a little bit. So it looks like the majority is by school, which it is. It's just the majority of the school is Hall County School or Grand Island public. But law enforcement is a large, and then family themselves. So, which is a number we really like to see here, because then we know families know where to call when they need help. So we have a large number, 26% of families making their own referrals into the crisis response. And I think that's wonderful. That's what we want to see, is that they know where to go when they need the help. And of course, mental health providers and probation are another higher source as well.
I think that data is extremely important for us to see too. It's reassuring in a way to see all those different sources. So thanks for sharing that.
Sure.
Does anybody have any other questions for Jill about her data? Okay. Abby, do you want to share a little bit about youth hospitalization?
Yeah, so unfortunately, I'm not going to be as informative as the others so far today. We are in the middle of getting the data for this group. I don't have it available today. Part of that is on me, and part of that is we just went through kind of a crash of our system. So we're getting through crisis. But so what I do have them looking into is emergency room visits, and then acute care admissions for youth and adolescents. Trying to have them look in 2 different areas. So just seeing what kind of trauma volume we are getting. I did ask them to look specifically into head injury as well within that trauma. And then also mental health admissions. That one actually is a little bit more challenging to get because of the way they get registered. So when people come in, sometimes they'll get registered and they'll have just kind of a general symptom that they're coming in with, you know, like high blood pressure crisis or something. So there could be some information, in my opinion, that might, we might not get the full complete data because of, you know, how specific it was when they first came in. But I've asked them to also try to look at it from final coding. So that's billing data. So we'll see how close that is. I also am working in partnership with Lacey Witt at Richard Young. And so she is compiling data as well in regards to how many children and adolescents they have been serving. So, so unfortunately, I don't have that information, but like I shared with the team previously meeting with this, you know, obviously when we do work with individuals, they're most likely coming in crisis. They may be here for a very short amount of time. They might be in the emergency room and then are medically cleared, and then they could go to Richard Young or they're going to Bryan. But there is definitely some challenges providing services to children when they're at a specific age. So I just had a scenario at one of my other hospitals where we could not find placement for an 11-year-old. There was a lot of violence involved and a suicide attempt. And eventually the child ended up going back home with mom and some safety planning because the recommended level of care was not available. So, and we called all around the state. Some of them denied because of the previous violence of the individual and felt they were too severe for their situation. And then other facilities were strictly full. So definitely challenges. The other thing that, you know, we may see children, and depending on the severity of what brings them in, if we are not able to take care of them for some reason, you know, maybe they need some type of a surgical intervention, then they do tend to get sent to children's or to UNMC. So I could potentially look for some data in that way too. I hadn't thought about that till now. I don't know if that would be of interest, but so I'm kind of asking if that's what we're thinking that we're wanting, if I'm looking in the right direction, or if you want me to request something different. But the data dive is going. It's just, hopefully I'll have it available soon.
I think I'm just still processing with you too, Abby. I'm not sure I have any specific questions. The gaps are always very enlightening to know. So the further your data is helping you to define those pieces, I think would be helpful. So yeah, I think your preliminary things you were talking about are helpful, and I'll just kind of stop there, pause.
Okay.
Just a quick thought also. I was at a gathering in Omaha with the NMC folks with Beacon last evening. And they continue, I mean, they're in Omaha, and that's one of the biggest gaps that they're seeing still is levels of care needs they're lacking from hospitalization through residential, etc. And so, it's statewide. Of course, it's exaggerated in our areas, but those gaps are blatantly obvious across the state.
Yeah. I did talk with, last week I talked with the executive director from the Bridge in Lincoln, which is a medical detox center. But it's for anyone that's 19 or older. And so I was picking her brain to say, are you familiar with any, in regards to substance abuse, any detox centers for kids? And she basically kind of just shook her head and said, it ends up being more outpatient type work and in-home wraparound support. Obviously, that's just one source of my information, but I would be interested from this group as we keep working, if there are resources out there that we're not aware of. But I mean, there could be a lot of data that could come from the hospital. We could look substance abuse, we could look mental health. It's just, again, it's only as good as the identification of it with billing and coding after the fact. And I wasn't quite sure with trauma. I couldn't remember, Denise, if we were wanting to focus more on, TB, traumatic brain injuries and those, or just trauma in general. I couldn't remember.
I don't think we fleshed that out very well,
Okay.
Abby. The only
Okay.
guiding things I'm considering is how to prevent people from entering the system. So when we think about that, we're defining the data systems that we're going to be marking our progress against, right? So, and I think too, that was one thing we wondered with bringing Peggy and her team in too. Where's the best place to find brain injury trauma data? Because we weren't sure where that lived. And what the best place would be if it does live at hospitals that we can keep digging there, or if it's other places that Peggy's maybe more familiar with.
Yeah, I can, here in the state of Nebraska, we have a brain injury registry. And we can we can talk to folks over at DHHS to have them pull out what the numbers are. It's only going to be capturing discharge data, but we can isolate it to whatever county we want. So there could be some really fascinating stuff out of that, and it'll talk about the age, and you can talk about how it happened, and it's all based on the ICD-10 codes, Abby. So we can ask about that.
Okay.
That does a nice job capturing those that are actually hospitalized, but to what I said earlier, we've got the majority that aren't being seen there, or even if they've had an injury for traumatic brain injury, if they've had an injury on playing sports, if it's managed by their athletic trainer, it's not captured there. Primary care physician, not captured there. Link, emergency care, it's like in the non-hospital emergency. So I think if we can get programs, I feel like I'm doing a lot of plugging here, but I think if programs are willing to do some screening, even if it's just for a short time, 2 or 3 month period, let's look at what the prevalence is there. And, if you find that there's not a high prevalence, well, then say, see you later, Peg, I don't need your help. But I think you would probably find that there is a higher prevalence. And it could kind of just change that conversation a little bit. But, and again, I recognize that brain injury is only one form of trauma.
Yeah. Yeah. I mean, I think the trauma information I should be able to get that one pretty quickly. because of our trauma certification, we keep very strict data for that. So I could just ask for traumas within the age ranges of 0 to, 19. And
Yes.
break it down.
I was gonna say, I'm more than happy to talk with Andrew over at the state and get there's a data work group right now that's focused on that, and we've got their attention. So is it 0 to 19 is what we're wanting? And then are there specific counties that we're wanting that information for? Or just kind of the central part and we kind of pick it out? I look at, the information Jill had, it looked like it was more about the area versus just the county.
I think we were initially looking at Buffalo County, but we also have that question that we always ask is how many people are coming to Buffalo County for services. So we are Buffalo County community partners, but we totally understand that we have services that people in our region come to, and that we need to address the whole system of that support and care. So yeah, if you have Buffalo County specific numbers, and then if you're able to kind of see who's using services in Buffalo County, if that's possible. And then we're also kind of looking at reentry, which kind of tells us a little bit about how well we're doing, right? If people are coming back into that system, if there's any way to track that. I love that you're pulling that brain injury registry pieces. And Peggy, I really appreciate you giving time to this conversation. I think your work is very important to this work. And I strongly believe that, I have a very personal connection to this. And so I'm really glad that this is a part of our conversations today. And I hope you are able to continue, or Brenda can continue in those conversations. I would share with the other group too, there is a piece that I do recall that comes out of that brain injury registry. When you have a brain injury, you get a packet of information almost immediately, which might be another prevention tool that we could be using to ensure that those that are returning to home in Buffalo County are getting very specific supports in that packet. And if I remember right, Peggy, that was some of the conversations we've had over the years. My injured brain is my trauma brain is kind of starting to remember some of these things that we've talked about in the past. So thank you.
Yeah, right now there is, for multiple reasons, they're not getting the information as quickly as they used to, but I think there's some efforts to improve that. I think right now we just sent out, the group that does it, send out information to all those that were on the registry in 2021. There was a hiccup within the hospital association stuff. So it's not as timely as I wish it was, but I think they're trying to improve that too.
I do just want to say on a side note, the importance of this work. I mean, we are seeing in middle to older adults now, the impact of some of these things not being addressed when they were younger. And it's one of our most challenging populations to find appropriate level of care placement for, like got individuals that are sitting here for 40 or 80 days that cannot get into a nursing home, probably need more of kind of like a supervised setting. And there's just not great documentation also of some of their previous disabilities. And so the work this group can do to help prevent that in the future, hopefully, would be great. Yeah, if you think of other ideas of data that you'd like me to search for, please, let me know, and I will get it as soon as the number crunchers can give it to me. So I tell them I don't understand numbers and data very well. I'm learning from you all, but I can definitely talk in barriers and gaps.
And I know I'm going to have to hop off here, but I'll work with Andrew over at the state to get the TBI stuff. And as soon as I get that, I'll send it. Denise, you're my contact and you can distribute it. Or if you just keep me on the list of people that keep coming to these meetings, I can share it next time that way too.
Yeah. Thank you.
Yeah.
Okay. Anything else for me?
While Nicole is still on with me, can we, Denise, skip the creating a decision-making matrix and go down to updates from the work group quick? Okay. Nicole, do you want to give a quick update? I kind of talked at the beginning a little bit about it, but. Oh, you're on mute. It's happening.
Oh, sorry. It's a struggle this morning. I will say I've missed like our last couple meetings because I was on vacation and whatnot, or I had a conflict, life. But we're kind of to the point where we're really looking at narrowing down some strategies and putting some action steps in place. Even if they're just small wins, but ways that we could maybe make an impact, and looking at the ages where it has the most profound brain development, and focusing in on them children. So that's kind of where we're at. I know we have a meeting coming up, I think. Sorry, I haven't looked at my schedule.
Yeah, the end of November, we have another one.
Thank you. So I have heard from multiple people that are attending our meetings that they're really excited about seeing some action being taken. So I think we have lots of people on board, and some people that I've talked to have said that they had kind of dropped out attending the meetings. And so we're pulling people back in, people that we need to have at the table. So I think that's been extremely helpful to have all them people that either touch these kids in one way or another, and really trying to find ways to embrace lived experience or expertise. It's kind of interesting because for the department, the meeting that I have to get on at 11 is actually a father's pilot, a father's engagement pilot that is like a nationwide pilot, and I'm a part of that, my team is. And a big piece of that is that lived experience piece. And we have a dad, a father that participates in our meetings with us. And he's like, I don't understand why you guys call it lived experience. Like, we all live this, like, so we're trying to like figure out what the right language is to use with that. And we've talked about lived expertise, you know, because we all experience life, you know. So being able to kind of pull that into our work with what we're doing with the collaborative has kind of been an important aspect that we're trying to address and figure out how we can make that happen, because we do value that and see the importance of that. So. I don't know how much of an update you want, like.
No, that was a good update. There's a few more people on the call that have been to some of those meetings. Do you want to give kind of your perspective about how things are going and where we're at? And Martha, I'm gonna have to call on you.
I'm sorry. The question was, how was the last steering committee meeting?
Well, not the steering committee, but the youth the youth and child adolescent meeting. How do you think things are going? Do you have any, Nicole?
I would say, yeah, there's a lot of really good energy. Like you had said, the group had discussed different ways to have a quick win. I think one of the things that came up from one of the groups that I was in was social media, just promoting some information to parents quickly through some of the social media platforms that some parents are using, and just trying to figure out what is that information that will be beneficial for parents. But Denise, I don't know if there was any other takeaways from that last meeting at YAC.
I think the group is doing fantastic work. I'm really excited about the leaders. We invited a few more leaders to step in, and they accepted that challenge. So we've got a really good, strong group of people leading that work as well as this team. So it's exciting to see.
I think we'll go back to that decision-making matrix that Denise had alluded to. So I'll hand it over to Denise.
Thank you. I'm going to go ahead and share my screen here with that tool so that we can kind of look at it. So a little history of this decision-making matrix. Along the last year, the board and the collaborative and the steering committee have all been having conversations about how do we make decisions together, and how do we know who's making what decision when, and what do we base our decisions on as we're moving forward? Just kind of that responsibility piece. So we, as staff, started taking a look at what might be out there, and a shout out to Tana Miller, who found this online, and we have been adapting it a little bit to what we thought could be a decision-making tool for the steering committee and for community partners backbone. I shared this with the leadership of your steering committee a couple weeks ago, and they're like, "Oh, that looks good, but how is it in the field? Is it worthwhile? Are others seeing that this could be something that is helpful?" So on your agenda, we have been like at that 10:55 time, we've been talking about this other work that's happening in the community, and how we need to be aware of that work, and how do we ensure that we're not duplicating services, and that we're helping the community see themselves in this work, because it really should be inclusive of all disciplines and stakeholders and sectors of the community. So in that, we thought this decision-making matrix would be helpful. So what I did is I took Matt Lohmeyer out for coffee, and we finally got that done, Abby. Spur of the moment, got together, went down to Kits, and I put this in front of Matt, and I said, help me walk through this. If you had this tool as you were beginning to take a look at funding for violence prevention in the community, would this tool have been helpful? What would it look like? And just kind of walk through it with me. So we got to step 3 in this tool with Matt. So I think it was helpful, because the first step is, do we see, and would be a question for like a CHI or another partner who has funding or a grant or some sort of connection or relationship that they see that's important. Is there a fit with that shared agenda? Which the shared agenda would be those impact statements, right? That we're preventing youth from entering the system, and that we're increasing access. And so he said, absolutely, totally see the alignment there with the violence prevention work that CHI was pulling together at the time. And is there a fit with the impact statements, the shared measurement, the backbone strategic plan? Absolutely. He could see the shared measurement pieces being really important. And in some respect, he said, I don't really even know what data has been collected. So what is that shared measurement system? So he's already asking the question that you guys just spent most of this hour talking about, right? How does violence prevention fit into the data that you're asking to be collected or to set as that baseline? And then when we got to 3, it was a pretty significant gap at that point. He's like, I don't even know what's been done in the area of violence prevention. I don't really know what the gaps are. And that's why we're calling meetings together to begin to understand that. So I did give him a workbook that we have created, which is that playbook to help define gaps around abuse and neglect. And so he was going to take that back to his team and take a look at that. So I just present this tool for you to just start looking through it, get familiar with it, see how we might be able to use it. Would we give it to other partners that are interested in moving some pieces forward, or if they have some funding, where's the best place to plug that funding into the collaborative work? So I'm just going to pause there, just in case somebody has had a chance to kind of look through the tool, or maybe you just have a very specific question about use. So I'm just going to pause. I think I paused long enough for it to be awkward. So I think the question that I would love to hear by your next meeting is if a tool like this supports your work and helps you to make decisions. And so I'll just leave you with that thought, and we can maybe revisit it next time we meet. How does that sound, Emily?
Yeah, that sounds good to me. Okay, next on the agenda. Is there anything that the Buffalo County Community Partners Board need to know or hear from the steering committee? Then any outstanding questions, anything we need to follow up on?
I'm not thinking of anything board specific, and I guess Diane's on the call still, and Nicole, we could have report back to the board at the next meeting on the steering committee.
Okay.
Diane, are you thinking of anything specific that the board needs to hear from this group?
No, but I think maybe it's a good moment to just to address that representation of this committee at the board needs to be like stabilized.
And it's been either Kathy Gifford, Dr. Schaefer, or Nicole, depending on who's in the meetings and then also attending the board meetings.
Right. And I think it would serve the board well if there was a designated person who was, you know, committed to being the representative of this committee to the board.
I will share that with Kathy, and because I know this is near and dear to her heart to ensure that happens. So I know there was a state school board convention today that pulled her out. We had several people that logged on and told me they couldn't make it today.
Do they do they get an update monthly? Is that the timeline?
Yes.
Okay.
They get an update. Usually Nicole is there to give an update on the collaborative. And
Okay.
if Nicole is in this meeting, then she also updates the board. And then if not, then it's Kathy or Dr. Schaefer. But it's every month there is some sort of responding back to the board.
Okay.
And it's two ways, right? So if there's some things that you want the board to know, or if you need something from that backbone, this would be the time to ask for those things as well. And we'll keep it on your agenda every month. I think sometimes we run out of time and don't always get to this part of the agenda. And it's always on the end of the collaborative agenda as well, but we never seem to get to that part of the agenda.
I can't think of anything right now. I think we're at a good part right now. I think if we would end up struggling getting the data, you know, I think that could be it could slow up our process and progress. And then that's when we maybe would want to kind of ask for some support from the board. But I feel like we are moving forward. That's just my personal opinion.
Yeah, I think there's been a lot of really good energy and ideas coming out of that work group. And I think we had the most people in attendance last time. I don't know how many organizations, but I think there were about 50 or 55 people in the room contributing. So I think we're off to a great start so far. And then the next collaborative meeting for that work group is November 30th from 12:30 to 2. So if anybody on this call wants to join, obviously you are welcome. And if we're missing anybody at the table, or if there's anybody additional that you want to invite to come, you can do that. And it's either in person at Hanny or Ram, or via Zoom if you can't be there in person. And then do we, Denise, have a next steering committee meeting scheduled?
That was the open question. We have been giving, what do I want to say, permission. That's maybe giving permission to groups if they want to take December off, just to spend time regrouping at the end of the year and preparing for the next year, and revisit our next meeting in January. But know that if you feel like not meeting in December, you would lose some of the traction that you are gaining right now with data collection. We're very willing to meet on December 17th. So it's really up to the group.
Is that December 15th? I feel like the 17th is a Saturday and I will not be on a call on a Saturday, Denise.
Come on, Emily.
Right.
Look, I'm very
Where
dedicated.
is your level of engagement?
I mean, that's a fair question.
I'm just kidding. I wonder if we could keep it scheduled and maybe like a week or so beforehand, maybe we could just send out an email and see how things are going with data tracking and if we feel like it would be valuable or to meet or possibly.
Like, yeah, I like that idea. Let's kind of see where things are at because we'll have another meeting under our belt too. So there may be some information that can just be shared out through an email in the form of meeting minutes or something instead.
That sounds good. And I think the other piece of data that I wanted to ask Nicole about is if we have any child abuse and neglect data or where that data lives, that I think would be good to add in. But I can revisit those that were not able to join us today and see if they can bring their details next time. And if Abby has more to share as well next time, that would be great. Anything else you want for your agenda next month?
I can't think of anything.
Okay.
Well, we really got through this agenda fast. It's only 11:15. So if nobody has anything else, we'll give back 15 minutes to your day. Abby, I know you're going to need that more than I need it probably.
You never know.
Never know. All right, everybody. Thank you for coming and chatting with us and we'll see you next time. Have a
That
good
was
day.
helpful.
Yep.
Thanks, guys.
Abby and
Yeah.
Emily, can I grab maybe 2 of those 15 minutes back from
That's
you?
fine. Mhm.
I am feeling